So the idea is now to continue a little bit what I was doing before, is because also I think for hypertrophic kind of substrates, it's very important to try to understand what's the underlying tissue, what's the underlying changes, and how does that translate into imaging findings. And so you see the typical things that you want to look at when you look at B-mode images of some of the hypertrophic myopathies. What you see is that when you look at the walls, when you just measure the geometry, they might be very, very similar. But actually, when you look at the underlying physiology, it's very, very different, and that actually translates also into the different underlying substrates. And so when we look at hypertrophy, what could be is that, of course, we have several of the primary ones, where the typical ones is, of course, hypertrophic cardiomyopathy with sarcomere mutations, but we can also have some other mutations that potentially lead to infiltrations. And then we have secondary, which is very often because of pressure overload, because pressure overload translates, of course, into hypertrophy, potentially exercise also. So you see athletes' hearts are, of course, also much bigger. So when we look at it, when you look at them as a whole, when you look at most of the imaging, you see they're very, very similar. But when you start to look at the tissue, both the tissue structure, but also the way it contracts, the properties of the tissue itself, you will see that is very, very different. And so what we really need to know is, can we find ways to phenotype these ventricles where we try to take into account this underlying tissue without having access to the tissue, of course, because we're not going to biopsy every hypertrophy patient. So as you know, what we have is we have structure, then we have function. I always say, or I always come back to using a lot of kind of blood pool Doppler, which I think is very much underused, because the dynamics of the blood pool Doppler is really interesting to look at function, even to look at systolic function. And as I said before, don't just go to EE prime ratio for diastolic function. There's much, much more information in there. And actually what we will show is that there's a lot of information in the time course, in the profile. It was already shown this morning by Dr. Mele, saying that in the guidelines, or that in some people are saying, it's like, don't only look at the measurement of strain, for example, but look at the strain patterns. And you will see that I will keep on coming back there, and even later on in artificial intelligence, this will be very, very important. And we will see actually that using the deformation curve, potentially together with all the other information, this is really important to discriminate, because very often with just the measurements of the geometry, we will not get there. And so here you see 4 different patients where there's the question is, do they have, for example, hypertrophic cardiomyopathy? And when you look at their kind of presentations on the B mode, they're very, very similar. Even when you look at some of the fillings, you see that they're very, very similar. And for example, these 2 patients here, kind of this patient, clearly has a gradient also, so an outflow tract gradient. But actually it's a patient which is also very hypertensive. So the question is this hypertension the underlying problem that is causing in the end the outflow tract obstruction, or is this a really true hypertrophic cardiomyopathy with a sarcomere mutation? So these things we need to try to understand. And sometimes, we might get genotype positive, then of course that's very easy, but very often we get genotype negative. But the problem is that we're still missing quite a lot of the mutations. So having a negative genotype doesn't mean that it's not a hypertrophic cardiomyopathy, or at least a genetically induced kind of problem. So we need to try to find ways to grade this. And we have, in a way, a clinical gradient where we see, okay, we look at symptoms, we look at the onset of the outflow tract obstruction and things like that. So that you can do, of course, but what we really need to do in order to understand it is try to figure out what's the underlying thing. And when we look at, for example, the deformation and we try to understand the deformation, as said before, deformation is load dependent. Now, the thing is, anybody that tells you that they found a load-independent parameter in cardiology, they're talking nonsense. I won't say even worse, but there doesn't exist any load-independent parameter in cardiology by definition. It might be more or less load-dependent, that I agree, but it's never load-independent. So you always have to keep that into mind. And especially deformation is load-dependent. We'll come back to that later on also when we talk about volume and pressure overload. So we need to take that into account. And then, of course, actually deformation depends on the geometry. Obviously depends on the contractility, because that's what we look at. Very much depends on the tissue properties. And, as I showed you before, with the septal flash, for example, but also when you look at post-systolic thickening, for example, in coronary artery disease, that is segment interaction. So you always have to look at how does a certain segment deform with regard to the other segments. And that's what we will try to understand. Now, when we look at hypertrophic cardiomyopathy, what we know is that hypertrophic cardiomyopathy, so the sarcomere mutation, will induce a structural change, and especially fiber disarray. Now, one of the things is that, of course, as I said before, we can't biopsy every patient, but one of the things which is also very typical about this is that although we have fiber disarray, the positioning and the extent of fiber disarray depends on every patient. Every patient is different. We know that it's predominantly in the septum, but we also know we have apical HCM, for example. But what you will see is that no patient is similar. So one thing already to know from this fact that we know that this is one of the underlying problems is that whenever you're going to use a technique which just takes the 6 segments and is saying in that segment we see that something is different, or any study that you read about HCM and they average these segments specifically, as still mostly is done in the literature, you know that this will be fraud from the beginning because the disease process is not like this. When we look at coronary artery disease, at least with a coronary perfusion territory, more or less we know where it is. So that means that patients with a similar position of a stenosis, there you can average segments during a study of what you're looking at. But HCM, by definition, you cannot. Although if you always look at the septum, probably you're going to do not badly, but the problem is, really this is dependent on the patient. That's important. So while we do not have tissue, what we do is, of course, we use family history, signs and symptoms, genetic testing, and imaging is going to help us quite a lot. Now let's try to understand. For example, let's first try to distinguish hypertension from hypertrophic cardiomyopathy. So the thing is with hypertension, we know there's pressure loading. When we start thinking about it, what is pressure loading doing to the ventricle? Well, what happens is that because of pressure load, you start to get that the wall stress in the segment gets up. If myocytes have higher wall stress, they hypertrophy, and they hypertrophy in order to get more contractile material and be able to really develop more force and then develop more pressure in total. Now, this is a local trigger, so this is what the myocytes feel. So we have to look locally how this changes. And actually, since our ventricle is not a sphere, we will see that there's no global disease in cardiology. Because of the fact that we have a kind of elliptical ventricle and actually an asymmetrical elliptical ventricle, every segment will see this differently. And you can see this, for example, when we look at the apex, and we know that the wall stress is, of course, related to the pressure. The higher the pressure, the higher the wall stress. But it's also related to the radius of curvature. The more, or the smaller the radius of curvature, the lower the wall stress for a certain pressure. So when we look in the ventricle, what you see is that the apex is actually the most rounded. It's like the smallest radius of curvature. So intrinsically, wall stress is the lowest there. That's also why the wall in the apex is much thinner than the rest. It's just because of this geometry, nothing else, the geometrical difference. If we look at the lateral wall, it's much flatter, so it has to be thicker in order to withstand the pressure. The septum is the thickest, but keep in mind, of course, the septum gets a kind of pressure from the other side, from the right ventricle, so that makes that the base is symmetrically with the same thickness normally. But if we have an increase in pressure, what now happens is that the flattest wall will actually feel this increase in pressure much more than the other. So the first trigger for the myocytes for hypertrophy comes where the wall stress is the highest, which means in the flattest region. And that's where you see that when you look at hypertensive patients, they very often have this basal septal hypertrophy, or septal bulge, or sigmoid septum, whatever you want to call it. And that is because that is the flattest part. That means that with pressure loading, the hypertrophy trigger will there be the quickest, and that's what they develop. And what you will actually see there is that because of this also, and because of this increased loading, the hypertrophy tries to compensate this increased loading by, of course, having more contractile material. Very often it doesn't fully does this, and what you see there is that in this basal segment, in the sigmoid septum or in the hypertrophy, you see that there's first stretching because of the high wall stress, then you have the systolic deformation, and you have a very important post-systolic deformation. When you see that in a pressure-loaded ventricle in the basal part of the septum, this is not coronary artery disease, this is going to be just because of the pressure loading. And that's also where I don't like the guidelines, because some people have been saying that before, where you need to do, for the analysis of the strain, you need to not include the septal bulge. Sorry, it's tissue, it's important, you should include it. So there's a couple of things that I totally don't agree with the guidelines, which is also the use of R to R for strain. I absolutely do not agree. I think you need to do onset QRS. But, I mean, I was not in the guideline commission. But anyway, what is important is that you have to look here at the basal septum and see what's going on there. And so trying to understand this, and actually what you see is that this basal septal hypertrophy is actually very, very specific for hypertension. You will see that a whole bunch of patients will have this, even well controlled. So in a study of very well controlled, kind of for years controlled with decent blood pressure, you see still that about 20% has this basal septal hypertrophy. And if you see basal septal hypertrophy, even if you now measure the pressure and it's relatively low, if you do a 24-hour blood pressure measurement, you will see that that patient has elevated pressures. So this is really important to look at that also, but what is more important is that this is related then with a local reduction of strain, which has nothing to do with contractility changes, but which has to do with regional loading changes. So this is important. Look at this pattern where in the basal part of the septum you will see reduced strain with post-systolic strain, and then you know that this is hypertensive related. And of course also related to this, what you will see is that hypertensives in general, partially because of this, will have less longitudinal strain. And you will see that that will be very often compensated with circumferential strain. And this is where we go, for example, to the HFpEF patients, because HFpEF patients, many are of hypertensive etiology, where you see that they have a good ejection fraction if you look from the radial or circumferential direction, but what you will see is that they have very reduced, and especially in the septum, reduced longitudinal strain, and that is very important to look at. So longitudinal strain helps there. GLS is an easy way to do it, because that is very robust, very reproducible, but it's actually the basal part of the septum which is the specific part. Now, to understand a little bit better what's going on in the hypertrophic cardiomyopathy, I just show you here some examples of a study that we've been doing in Barcelona, where we actually had myectomy patients. We took the myectomy tissue, and then we imaged that piece of myectomy tissue at very high resolution. Well, obviously we did echoes and MRs and these. We took out the tissue, and then we put it in a synchrotron in order to get super high resolution structural images. And what you then start to see is you can try to understand what the differences are. And we were lucky in some way that one of the patients was a clearly genotype positive patient with HCM, and the other one was actually a genotype negative with severe hypertension, and in the end a hypertensive induced such a bulge that it had an outflow tract obstruction that the patient needed a myectomy in order to relieve that. And so when we look at it, what you see there is that in the hypertensive patients, we see a little bit of late gadolinium enhancement in the endocardium. And even in the beginning, the radiologist would say like, oh no, there's no late enhancement, because it is actually kind of at some trabeculation. So this is not specific. But when we took out the tissue, there was clearly a white layer in the endocardium. So it means that there was, of course, some kind of fibrosis and scar. And so when you then look back, then you say like, okay, this is probably late enhancement. Well, obviously, in the HCM patient, you see very typically at the insertion points of the right ventricle, you start to see this very typical pattern of late gadolinium enhancement. But what is much more striking is when we look at the deformation. So these are patients that have very similar ejection fractions, super similar geometry, both have an outflow tract obstruction, so we cannot discriminate them based on that. But when we look at the strains, what you see is that the basal strain here, basal septal strain in the hypertensive patient is reduced. There's post-systolic deformation, but there's a continuous gradient where the base is the lowest, and then you go towards the apex, it normalizes, and the lateral wall is reasonably normalized. When we look at the HCM patient, though, what you now see is that actually what we see now is that the lowest deformation is not the basal part of the septum. In the hypertensive it is. It's always the more basal you go, the less the deformation. In the HCM patient, what you see is that the basal part has some contraction, it's overall low. Then you have a region where there's no contraction whatsoever, and then you again have contraction. And also, this is like no contraction, no deformation whatsoever. So this is not just reduced systolic with post-systolic, but this is almost no deformation, maybe a little bit of post-systolic, but in general, you see that. So you see here in areas, and they can vary in patient, that can be anywhere in, as we said before, in the septum, it can have any extent, that will be depending on the patient, but what you see is you see relatively normal strain patterns, very abnormal, relatively normal, that is very typical HCM. When you go from a gradient where you say the basal part reduced post-systolic, and then you go to normalizing, that is very typical hypertension. And the reason for that is actually this. So these are the synchrotron images from this tissue that was taken away. So here you see this is the hypertensive patient, this is the hypertrophic cardiomyopathy patient, and what you see here in this hypertensive patient, you see all the myocytes are nicely aligned. We know myocytes have a certain alignment. I'll come back to that in a minute. But you see all the myocytes in the same direction. This is super important in order to get normal deformation. When we have hypertrophic cardiomyopathy, we have myocyte disarray. And you see here, this is totally disarrayed tissue. You see myocytes in this direction, and next to it, you see a myocyte in that direction. And you can already imagine, if this myocyte contracts, it contracts, but it has to thicken, of course, also. Then this myocyte contracts, but it prevents the other one from thickening, so it prevents from contracting. So if you have these myocytes, they will develop a lot of force. They try to contract. They cannot because they work against each other. But locally, the wall stresses are enormous. That's also why you see that hypertrophic cardiomyopathy patients, when they're children, they have little fibrosis. The older they become, they have more and more fibrosis and late enhancement because they just the whole time contracting against each other. And of course, at some point, this leads to failure and to fibrosis. And if you look at these fibrosis patterns also, you see here this hypertensive one clearly has this interstitial fibrosis. There is obviously fibrosis in an hypertensive, but at least the overall organization of the tissue is spared. While in the HCM, you actually also see that there's vessel abnormalities, but you see that this tissue is very abnormal. So intrinsically, this HCM tissue cannot deform. Where you have fiber disarray, sorry, there's no deformation. And you can actually pick this up with echo. The HCM, the HTN, so the hypertensive, has a bit of fibrosis, so a bit less deformation, but the main thing is it has increased local loading because of the overall geometry of the ventricle. And so this way, here you see actually nicely this kind of distribution of fibrosis. You see in the hypertensive, you see it in sheets. It's very organized. It's organized tissue. The HCM is totally disorganized with regard to tissue and with regard to the matrix. So you see that you can explain these tissue patterns or these deformation patterns by knowing the tissue. Which means obviously when you look for these deformation patterns, you can infer what's going on with the tissue. And this is the way that we can actually try to understand these. Going quickly to some other of the underlying hypertrophic substrates is, of course, amyloid is one of them. What you see very typically in amyloid is that actually when you do a ring motion, there's no longitudinal deformation. Neither septal, neither lateral. This ring is static. Very often with these very, very large atria. And what you actually see, and this is something which is also very interesting to look at, is atrial contraction. Because, for example, when you start looking at filling patterns, very often they have problems with atrial filling. Not that they're in atrial fibrillation, but actually I think honestly that there's a activation problem of the left atrium, specifically because of the deposition, of course, of the amyloid. And actually this is what they die from, because if they really lose all their early filling and the atrium is not contracting, obviously they're not filling, and that's their biggest problem. So when you look at these, what you clearly see is when you look at the strain patterns, as I said before, overall there's no longitudinal motion. So looking with M-mode, that's very, very useful to look at global motion. But what you see there is if you put strain in, what you see is that actually in the apex there's still some strain which is preserved. But in the basal part you have virtually no longitudinal strain, so you see this typical pattern of what we call apical sparing, or Japanese flag, what some people say. And the problem is that amyloid is predominantly depositing in the endo and epicardial regions, predominantly endocardially, which means that you lose all your longitudinal function, and the only thing that's left is a little bit of circumferential function, so you see a ventricle which contracts this way. And this strain pattern is very, very typical for amyloid. If we then move on to, for example, Fabry, but some of the other of these kind of genetic diseases, what you very often see is that it's now actually the lateral wall, which is, or the intralateral wall, which is affected. And what you actually see is that you see the very typical patterns of decreased deformation and post-systolic deformation, now not in the septum, because that's pressure related, but you see it in the intralateral wall, for example, and that is genetically related. And again, this is very specific. So if you see a very hypertrophic heart, there's no kind of indication of coronary artery disease that could explain some of these things, which is probably unlikely when you have very thick walls everywhere. And you see this kind of abnormal deformation in the free wall of the left ventricle. Think about any of these genetic, Fabry, Friedreich's, there's a couple which are actually, even Pompe, this kind of things, are very similar in this type of patterns. So if you start to look at deformation patterns throughout the ventricle, try to link that to the physiology that you know, you can actually figure out the different etiologies. And I think this is very important. So it's really strain patterns which matter, not strain values. So even if there's differences locally, you could measure, for example, the basal strain and compare it to cutoff. Unfortunately, local strain is not very reproducible. Global strain is rather reproducible, but values of local strain are not reproducible, but patterns of local strain are very reproducible. And there's also a study that we did at some point where you can really indicate that people, once they know what to look for, they can recognize it, even if the value of the strain there can be different. Now, what's the extra role of MRI? When you look at it, well, MRI is quite good in looking at structure, of course, but as I said before, it's not the structure which in hypertrophic cardiomyopathies will make the difference. So, of course, you can measure the hypertrophy a little bit better and things like that, but it's not always that this is very important. Of course, in a very bad echo patient, obviously you do an MRI in order to do it. But once you do it in echo, whether it's a millimeter more, less or more that you measure in the thickness, honestly, I don't think that's going to help you a lot in the diagnosis. What is much more important is look at the specific changes of the tissue. And this, for example, you could do with MRI. So you can do at late gadolinium enhancement. You can try to look, for example, at T1, also an amyloid and things like that. So this helps, but again, the strain patterns will tell you the same thing because they relate it to the underlying tissue. So wherever you have a problem with strain, or you can't do it, or your echo lab is not equipped for it, then MRI might be something that you can do. Or in a bad echo patient, of course, you can do it. But otherwise, MRI will give, I think, relatively little extra information. And also, for example, late gadolinium enhancement, you really have to think about, this is not fibrosis necessarily. This is different changes or differential dynamics of contrast. And for example, when we look at the hypertrophic cardiomyopathy, you see that contrast can get trapped in this disarray tissue without presence of fibrosis. So you really have to see how you interpret it, but then it can be useful. And then you see that indeed, based on, for example, T1 and extracellular volume, which now some labs can do, but which is still quite tricky, I have to admit. Not everybody will do it as good as the others. You could do that also. But honestly, I think looking at the patterns of the deformation, once you're trained for it, will be almost as good. So important, again, what you need to do in hypertrophic cardiomyopathy, just like you need to do in CRT, is try to look for specific signs of the underlying etiology. And each of them, when you start thinking about tissue changes, loading changes, then the cardiac mechanics will have a specific pattern that once you recognize it, you can actually use it diagnostically very well. Thank you very much.